So I think this is another episode of the Shoulder Master series, and every time we keep it simple to not to have the master's opinion, the master's note, and to not too many confusions. And today we have I could be slightly greedy enough to say my dear friend, but he's a big guy across the globe. His name is all across. You see Sikot, you see it, and it's all Earth Christos, and it's not that way. Just now we were talking that we knew each other for 7 years, and time flies. And he is an academician. He is an excellent surgeon, which I have been amazed. And he has a lovely family, right? So there's a
Thank
lot
you.
of things that I really love him. And the best part about his is in two parts of the country. He is a German. He's also Greek. So we have mythology with the beauty of German engineering as well. And I don't think I need to introduce him in detail because I'm sure whoever knows Christos, everyone knows Christos. He's done excellent job on shoulders. He's done excellent job on his elbow. He loves speaking on elbow. So I told him, yeah. And today I think we're gonna have an interesting topic. Really mind blowing. I was more than the audience. I personally, I'm eager to hear from him, and I think I wouldn't waste too much of time. He's a busy man, so we don't want to waste his time, valuable time. And thank you so much, Dr. Christos, for taking a small word from a guy like me and accepting it as an invitation. It's really an honorable thing for our Indian and global audience, and also Ortho TV. Thank you. So I leave
Uh,
it to you right now.
thank you very much for your kind words. Thank you very much. And thank you for the invitation. It's lovely being here with you again after 7 years, man. It's been 7 years. It's amazing how time
Yeah,
flies.
yeah,
So today we want to talk about um, if we actually misunderstand the rotator cuff lesions. And also, we want to talk about the age-based patterns of rotator cuff tears and their implications. I have to say here and stress here that and thank actually these a couple guys more that we actually did the a study on it. You can see in a bit because I was when I was scoping my shoulders and doing my rotator cuff tears. I was thinking about like the theories of the past. I'm like, it can't be really that. It can work like this. And then I met Freddie Montoya from Chile, and he already had the idea set in his mind, and we actually found each other, and we're like, yes, and then with the help of you from India, Sasi, then we made this real. So what we think before, what was the main theory that we used to believe from even from near era? We all said, oh, it's a subacromial impingement. Oh, what is it? It's the acromion. What the thing is, even nowadays, I still hear quite a lot of people maybe that don't have to do like much with the shoulder. They just do it sometimes from scratch, or they work with it as well. Um, Not just shoulder. They talk again about impingement. They interpret every shoulder pain into impeachment, even in 20, 25-year-old, and even more now I've come back to Greece, and I hear it a lot here as well. So there's a new evidence that the rotator cuff tears don't come from subacromial impingement. They originate from the biceps pulley or intra-articularly. And we see more and more studies show that we don't need the subacromial decompression and so on. And we know, again, the theory from the past, we all know that the delta muscle actually pulls the whole humeral head proximally, and then that causes bursitis, and then it causes the rotator cuff tear. That fades away through the time, though. So what was the study objectives that we had? We want to investigate the relationship between age and the rotator cuff lesion progression. At the same time, want to assess lesion patterns that we see either in younger and in older patients. And of course, determine the correlations between the specific lesions. So what did we do? We had a prospective study from 19 to 23 with 487 patients. We had to exclude some shoulders, which ones? The traumatic tears, because of course there is another mechanism. There is a traumatic, as the trauma is what causes the tear. And the overhead athletes. So where we have another theory, and you must know as well, Knut Beitzel, from a good friend from Cologne, where he's talked a lot about it, and he's written a lot about it, about the so-called posterior superior impingement and so on. So what we did, we had a standard arthroscopy by single surgeon. We classified the lesions for the subscap tears. It was Lafosse classification. We want the size of the tear of the supraspinatus. That's why we use the Beckman classification, SLAP, and at the same time the rotator cable, if it's anterior and posterior cable. It's really important. I have to stress this. You're going to see later why. So as I said, 487, 270 females, 217 males, and the mean age was 57 years. With below the group, two groups, we had two age groups. The one below 52 years, that was 30%, and then above 50, it was 70%. What we mostly saw was, like, in the group below 55 years, there was a high medial and lateral pulley lesion, and that was 95 and 96% respectively. On the other hand, in the ones above 55 years, there was an advanced pathology by having 100% lateral pulley lesions, which caused a bigger size, tear size, the Bateman 3 to 4, and at the same time, the subscap tears like Lafosse 2 to 5. This is an example. This is an example that shows the lateral pulley lesion. You see, actually what it looks like is the yellow arrow there. The lateral pulley lesion causes then afterwards some migration of the long head of the biceps posteriorly, and that causes, you will see here is a A3 pasta A3 lesion. What's really important that comes in contrary with some studies, we found an association in medial pulley lesions with slap tears. That comes in contrary with again with Patcher from Germany, where in his study he found out that there was no correlation between medial pulley lesions and slap tears, but that is because, and most probably, they didn't include the SLAP 1 lesions in their study. And of course, it's with age, we had more advanced injuries, more advanced tears. I want to emphasize that crescent tears, they were more common in younger patients. And actually, in our group, they were the youngest patients. Here's an example of a medial pulley lesion, as you see here. What's only weird about it, that with the medial pulley lesions, we didn't really find some subscap tears. Yeah, there was an association with the slap slap lesions, but not directly from the beginning with the subscap tears. Through the age, yes, like with advancing of the age, yes, but not in younger patients. And this is an example of the crescent tear in, as I said, in the youngest patients in the group below 55, and we see the good quality of the tendon. here. With progression of the age, we had a progression of the pulley lesions. As we said, it was 100% lateral pulley lesion. And we see here, in combination with partial tear of the long head of the biceps, a subscap partial tear, and this supraspinatus tear, where we see the anterior cable is affected here. I want to stress this because with age, we see more the L or reverse L-shaped tears. That's a good explanation about it. So, rotator cuff tear progression. So, what did we actually find out? Yes, rotator cuff lesions, most probably after our findings, originate at the biceps pulley. And with age, there is a propagation from the anterior cable to the posterior cable. That stresses again the thought that mostly with age, we see more and more in either L or reverse L-shaped tears. There were great implications for scapular biomechanics and shoulder stability, what I'm going to show to you in a bit. So, first of all, the common old theory that says it's everything subacromial impingement, we see that actually it's not the case, because most of them, or all of them, they had some intra-articular, or the tears that we found, they had some intra-articular origin that aligns perfectly with the paper of Awe. That was a cadaveric study that where he stated the rotator, or he saw, actually, he investigated the rotator cuff tears start at the long head of the biceps tendon region. But that comes in comparison on the other side with Kim's theory, where he said that the tears begin posterior to the long head of the biceps, and especially it was 12 to 14 millimeters. What's the superiority, though, of our study there? That we had an arthroscopic view and we actually could see it, diagnose it. And this study was around 300 shoulders, big sample as well, but it was an examination with ultrasound. And sometimes ultrasound can be a bit subjective. Of course, they're perfect sonographers, but I don't think that's something that ultrasound can beat arthroscopy. And then we come a bit further to actually explain all these things about long biceps and the pulley. There's a very good study from 2015 that comes from Brazil. And this is a paleontological study. And what does this show? As quadrupeds, if someone believes in evolution, because evolution plays an important role, and as quadrupeds, the long head of the biceps acted like a passive stabilizer. Now, as bipeds, because we walk normally, though, now, there is no function in it. They actually state that there is some limitation of the motion. And then we go a bit further to explain it. Scapular dyskinesis, or nowadays as STAM, scapulothoracic abnormal motion. We see more and more papers come out talking about it. And Bassem El-Hassan has written a lot about it as well. And this is what causes it is the impaired the tear. I mean, the rotary tear is the impaired neuromuscular coordination and muscle elongation because of the scapular dyskinesis that causes excessive tightness of the pec minor that affects the serratus anterior. The serratus anterior is the one that closes the scapula and prevents the winking. Of course, we can categorize them like 1, 2, 3 4 and 3 is the so-called that propagates the subacromial impingement, but there is something more behind it. This is an excellent study that came out a couple of weeks ago. And I was really glad when I saw this study coming out because it kind of proves the whole idea that we have. And there's another study that comes up from us, and I don't want to give it away, talking about scapulopexy, how important it is to alter the biomechanics of the scapula in order to have better results, in order even to prevent the rotator cuff tears. And what it says is the scapular dyskinesis in medium and sized full thickness rotator cuff tears after subacromial lidocaine infiltration after having a rotator cuff reconstruction. So after rotator cuff reconstruction, we had a problem that biomechanical scapular dyskinesis, the biomechanical problem of the scapula. And by injecting this lidocaine subacromially, that reduced the scapular protraction. I'm going to say a bit more about this in a bit, our assumption, our theory, but we haven't proven it, but this is our theory. I'm going to tell you in a bit, more in a bit. And let's read it together. It's really important. And the conclusion that I had is 6 months of rehabilitation treatment and the post-operative period is not enough to fully eliminate scapular dyskinesis. Should we think about doing something more about the scapula after repairing a rotator cuff? There's a question maybe for another study and for another talk. And this study also talks about the impact of faulty posture on rotator cuff tears. Because what's our theory behind the rotator cuff tears? And our study kind of proves this whole thing. Why do we have though these pulley lesions that we found out? Because in every single patient that we scoped, we had this pulley lesion, either medial or lateral, and why we had even more and more with age, more lateral pulley lesions. Because the explanation is through evolution. When we are quadrupeds, if you believe in evolution, like apes, we were walking like apes. So we had more pull of the trapezius, we had more scapular protraction. By walking now as bipeds, the protraction more or less stayed. That caused an opening, kind of an atrophy of the serratus anterior, especially in women, because we see the stem more in women than men, because it's, of course, the muscle belly is thinner. That causes this protraction, and this whole protraction, what causes the faulty posture? The tightness of the pec minor. And because of this time, we all know the pec minor syndrome. And because of this, would be an explanation. We cannot prove it perfectly now. That causes all the pulley lesions that we actually see in this study of ours. What were the clinical implications though of this study? We have to detect and prevent posterior propagation because it was from anterior to posterior cable. We have to stop this either conservatively or even surgically. In younger patients, we have to address the anterior lesions early before they propagate. And of course, in older patients, we have to treat extensive degenerative changes. But again, scapula comes into account. Maybe we can prevent everything by just correcting the scapula, either with physiotherapy. What I actually tell all of like the physiotherapists that I work with, I like, please deactivate the trapezius, stretch the pec minor, and activate as much as you can the serratus anterior. There's some excellent exercises from Kibler. There's a nice paper from him. There are pictures with the exercise that can someone do. So scapula is a thing, or even corrected mechanically or surgically by doing a scapulopexy. But it's another topic that we can maybe talk about in the future. The paper is hopefully is going to come up. Is going to come out like in a couple of months. So what were the strengths of this study? We had a large sample, like 487 shoulders. Of course, we had no control group at the same time and no longitudinal studies to track the progression of the lesion. So in conclusion, rotator cuff tears, as we see, begin intra-articularly around the biceps pulley. There is an age-related progression from anterior to posterior that gives us the idea, at least what I see and what we saw, that after some age, especially more than in the group above 55 years old, there was more L or reverse L tears starting from the anterior to posterior cable. And there is an importance of early intervention and age-specific treatment. And that's why in the future, except from the longitudinal studies that we can do to track the lesion evolution, we need to explore preventive strategies, learn more about the scapula kinematics and biomechanics, and maybe there's an idea of performing a scapulopexy. We have a new technique coming from, I have to say, from Freddy Montoya, not exactly the technique from Bassem El Hassan with using the hamstring tendon without using a tendon, but kind of politating the teres major and the serratus anterior. So that's it. I hope I didn't tire you. I hope I was clear, and the whole sequence and the whole understanding of the study and how the rotator cuffs propagate because of the pulley lesions, and what we can most probably do to prevent or even treat these lesions. Thank you very much, and would like to ask you, do you have any questions?
Yeah, so I would say it was an excellent talk and it was mind-provoking and it put me a lot of questions as well. So,
Pro
I mean,
Provoking is always my second name.
so you've always been, I mean, I think this is the need of the hour. So let me ask you, I'm more eager to ask you questions for personal stuff. So I think I totally accept with you where when we all did our fellowship programs, one of the commonest thing that we see is an isolated procedure of acromioplasties and subacromial decompressions, which was at least even now it's been practiced along. And I think today among the shoulder surgeons and community, it has been an absolute procedure, except then we have to create room and space during our repair. It is not a therapeutic procedure, which again, you made it clear because we go again to the cost that impingement is not the isolated reason for causing a cuff tear and biceps. So, how would you like to look? I mean, you've been super clear in your study to provoke the thought that biceps could be the pulley system, could be the originator spot of the tear. And now we also clear it always the lateral regions for slightly on the elderly and medial lesions for on the younger side. And I have a personal question. So now,
Yeah.
if we again we can split up the topics into balanced shoulder, unbalanced shoulder. It's slightly away from what you have talked on the ethiopathology. Now we end up getting a lot of 60-65 years old patients who are decently good with range of motion, but if you look at the MRI, they have a massive tear, but then decently, I mean, kind of a balanced shoulder, but they have a mild pain, but decently better after physiotherapy, physical therapy, training their muscles, what would you like? I mean, what would you like? But your MRI shows a massive tear. What do you think is today's evidence to give a right treatment for the patient? Should we tell them that how do you rate them? Should I repair the cuff to prevent a progression? Or you are perfectly balanced, I just want to leave you alone. So what do you think is your personal practice, and what do you think on that evidence on that as well?
Yeah. Um, the thing is, if it's 60-65,
Yeah.
I would still treat it. If you said like why? Because this can propagate and go to the back, like to posteriorly. So it can become even larger because we see the progression that comes more and more. That's why we divided this to groups. So if we see a massive tear, even a partial repair would help this patient first. And second is, why does he have at the moment mild pain? Okay, because all the other muscles, most probably the periscapular muscles, work good. The thing is there. Sometimes you're going to fail. The compensation is going to fail. And because of that, because again, this study from all, he showed that once it gets bigger, infraspinatus is involved as well, then we get even more of a posterior migration. So we have to prevent this, and at the same time, then afterwards, work on the scapula. And work on the scapula in order for him not to lose. Because you saw the new study, they're like after rotator cuff tear, and I see it in my everyday practice. I do rotator cuff tear. Some of them come and like, oh, doctor, I can come up to here, and then I just stabilize the scapula, just like this, or sometimes just put a finger exactly in the inferior medial angle, and they go pop. I'm like, okay, that's where you have to work on. That's what I tell them. You have to work on that. And that's why I totally believe that a shoulder pacemaker is makes a lot of sense. Makes a lot of sense. And then what would like actually to start, but I don't know if we were gonna do it. I think maybe Freddie's gonna start doing it, and then me. Do a combination of scapulopexy and rotator cuff reconstruction at the same time, and maybe a pec minor release.
So sexy pecs, yes,
So it's
everything.
really sexy, I know, because Freddie has some excellent results with doing his technique. Yeah, from it's application at the end of the day. This capulopexy. He uh, we do 3 holes in order to cover the teres major and the serratus that go behind the scapula. Here is the, and then we pass suture tapes or fiber tapes. So we kind of increase the attachment of the muscles and the tendons. And that
Okay.
helps the scapula. It's not a complicated operation. It's not as it might look, but it's not at all. Um, Maybe that would be an answer for the future. I don't know yet, but of course, at least with physiotherapy, maybe with shoulder pacemaker, we have to improve at the same time the periscapular muscles.
Makes
But
sense. So,
of course, addressing 60-65 for me is young. I would address the tear.
so I think just for the audience sake, I take it as massive cuff tear, even though it's balanced, would still go for a repair, obviously to prevent the progression. But most
Exactly.
important to take care. I think I agree with Christos. Every one of our shoulder surgeons do understand we have underrated scapula and we have missed scapula for a long till Bassam El Hassan, which was who's our enlightened, and he's a great man. He started talking about that, and that's when we realized. So it really makes a difference. I think we should, the one thing I loved about Christos is I think very soon he would come out with a fixed rehab scapula protocol for us so that we could copy and paste it in our practice. That would be
Yeah,
great.
let's see. But
Okay.
even the first one that talked about it was Kibler, actually. They
Yeah.
would categorized it first, and then Bassem took it and he took it to the stars.
Yeah. Too hard to base it. Yeah. That puts me in another question, Dr. Christo. So, you talked about surprisingly about pacemakers. So, what's your experience with pacemakers?
It's actually very good, very good.
So, I mean, in
And
what specific
especially
category
for posterior subluxations,
Mhm.
not the structural function ones. For me, it's the only way to go, because even if you operate, I've done it. I've operated. I've done it like application of the posterior labrum, application and of the capsule as well, in order not to have this posterior subluxation and stuff. We know, because I don't have any experience with the osteotomy there of the glenoid osteotomy, but that failed as well. So it doesn't matter what you do, all treatments are going to fail in the posterior subluxation, especially in this case. The shoulder pacemaker makes a difference. Maybe it helps a lot. It helps a lot. I had a patient, and it was actually two, but this one ended up with a reverse in the age of 33. I started with plication of the posterior labrum, and I continued with a bone block, posterior bone block. Just yeah, the superficial how is it called, replacements. It comes out in German anyway. And then he was having such a pain, so he's like, give me the reverse, I don't mind. And then he's happy with the reverse. So because all these people are going to end up with reverse anyway, you have to tell them. But you don't have to operate them without having um, any good results. So you better use the shoulder pacemaker, because scapula does everything.
That's really lovely to listen. I personally have no experience with pacemakers, so I think that's a lovely answer that we all have to learn.
And the thing is, if you even have the software, it's even easier, because it detects actually the problem, and you don't have to do anything. It corrects it on its own.
I saw it in Germany, and I'm sure they're going to get it soon to India and Middle East.
Yeah, the Philip Moroder was the one that developed it, but Madovani is the one that actually it's an Italian company, Neuroline.
I did speak to Philip also in that. I think that's a part that we all need to understand and push it across. Another question from this perspective as well. Now, we do repair a lot of calves, and if you look at the retear rates, it's over the bloom, we have evidence saying that it's about 24% to as good as 84%. However, the quality of repair, however, the good of hands may not be Dr. Raj, but Dr. Christos does it, or I mean, double row, single row, whatever the techniques we do. But and we also have the evidence that not all retailers have a symptomatic bad outcome. Only 20 to 30% of them have an outcome. So again, I'll go back to my question again. So with this kind of a picture, let's say a 65 years old guy, I mean, I'm just trying to understand myself personally. I would do his repair right now. Are we, if we put him on 3 months of physical therapy, and even though his MRI shows a massive tear, and he's doing very well, he's happy, are we going to achieve more by doing a surgery with the claim that we're going to prevent progression when we still have a documented evidence of at least more than 30-40% re-tear, and especially massive tears? Or we should just leave him alone, have serial follow-up MRIs? Oh, what is your take on it, Doc?
At first, a patient that doesn't have pain, you have to convince him first. That's a
I said that's the hardest part.
yeah, exactly. You just have to talk to the patient. You see, this is what I believe. That's what's going to happen, and you can end up with a reverse at the end if you just leave it. But otherwise, if he doesn't want to have the surgery, you just tell him work on your scapula.
Correct.
Yeah, but you have to talk to the you have to talk to the patient. Sometimes, yeah, you're right. If they have no pain at all,
Yeah.
so it's hard for me to operate on them as well. So because there's a chance there's gonna even, but I want to say something else. Even after re-tear, the clinical outcomes are good. Nevertheless, that's what I tell my patients. Even if I fix it, if I repair it, and it's going to be torn again, so the clinical outcome is going to be much better. So, and they mostly they accept it.
Yep. So
Yeah.
as you rightly told, this is an option that we all, I mean, it's especially for the audience who's taking up shoulders things. I think the doubt even perceives for the highest of the ladder. We have to put the options to the patients because we have still not realized. Obviously, there are benefits of repair, no doubt about it. But as Christos said, that we have to have a detailed discussion on that.
Mm.
Uh, do we have time with you? Can I go for a couple of more questions from these things?
Yeah.
You don't mind? Yeah. So the other perspective about the biceps. So are you a biceps killer or a biceps saver, and what's your philosophy on that, especially because I'm sure from now in 2 years you're going to be the man behind biceps right now. Your paper, I mean your research. I mean, I think this is the right way of thinking. Personally, listening to your talk, we have always understood it's not an extrinsic pathology that causes a cuff tear, and then it's within the cable that happens. So
Don't, yeah.
what would you do how do you manage the bicep, and what is your protocol of managing the bicep when doing a cuff repair?
Um, if it's a normal medium-sized tear, as I always say, arrivederci. And I do, as I always say, the Koukos technique. So I go from the anterior portal with my scalpel and I go, punk, and I'm done.
I like it.
If it's a massive tear, there I use it sometimes as a SCR and as an augmentation as well. So I release the transverse ligament. I bring it to the back. It's actually a
So you do the
countryman,
rerouting.
Butsiadis.
So
I, keep, I
you do the rerouting it. So you're gonna re
exactly. I take it to the back, and then I start repairing it with the cuff, with the supraspinatus tendon as well. And then though I cut it distally.
okay. Makes
Yeah,
sense.
there are some studies I think from China that actually show there is no difference if you cut it or not.
That was my next question I was about to ask you.
Yeah, but there is a saying in German,
Yeah.
sicher ist sicher,
Wow.
sure is sure.
Okay, this is lovely to hear from a Greek man. Lovely. So in basic words, you do tenotomies, and you're not a great fan of tenodisis. That's why I take
You know,
it.
these is just in young patients and in these ones that really care about the aesthetics.
Okay, makes sense. And in massive tears, you try. I think I totally accept your philosophy to keep this as a natural strut and a graft, so-called the biceps SCR or different procedures, and we can work
Yeah,
on.
not that much as an SCR. It's more like an augmentation. So
More
I
like a
might have more bread, as I say, to heal.
Now, the last I would maybe put last question is, what's your take? We have more products coming on biologics. We have regenerative patches. We have, and I don't want to go to the brand specific ones, but what I mean to say is that these are something. Forget about the complete tear. These are philosophies being taught to partial tears with the belief that we could stop the process at the start of it. So
Mm.
I don't know. So I've used a few patches on them, but I would know your presence on them. I mean, are you still convinced to use these kind of patches for partial tears or?
I, I have to tell you, I have no experience. Why? Because Germany and Greece are poor countries. Especially in the private sector in Greece, you have to kind of save for the patient. So if I use this thing that costs 3,500 euro because
Yes.
the patient pays from his own pocket, no way. And on the other hand, in Germany, because there is a fixed amount for every surgery, if I use these patches, the hospital, the president of the
Okay.
hospital is going to come and kill me, like this. So I have no experience. I have no experience. That's why I can't really express. I
I
can't
totally
say
agree
anything
with you.
about
In
it.
my practice in India, it's very hard because now I'm in Dubai. I have the luxury of using these things, but still there's a struggle here because of the insurances and their DRJ. But what is your
But
scientific philosophy? I mean,
I,
forget. But
I think it helps because I know some people from Portugal. They were talking to me about their results, and Andrei Popescu. They are saying that it's amazing. They have, in the meantime, zero retear rates.
yep, this is
That
this.
was it wasn't a formal discussion.
Yeah, but
It
still,
was an informal discussion, but they said we have no retears anymore. So I have no other. I just believe it.
so I
But it
think I
makes sense. You give
yeah, it
more
makes sense.
biology in
Yeah.
there.
I've not great numbers, but I've done more than 38 or 40 patches, but not for partial tears. Especially I use the regenerative patches, and I've taken some MRIs at the end of 6 8 months. Now, as you rightly tell, we have always seen the imaging after 8 months, oh, beautiful done cuff repair, but the tendon quality is always the healing is always a meshy. Now, what I've observed is that the tendon thickness that gets reconstructed with the patches looks promising, and maybe I personally I'm in too small numbers to say, as you told, informal. So I think it definitely has a take on the retear rates. But I think what should be explored is on where to use. We still don't have a clear. It all goes by our judgment and stuff. So I don't know.
Yeah. I don't think if we have any studies.
Any
If you have any studies,
consensus?
please tell
Yeah.
me, share them with me.
Yeah,
Because I
no,
don't know.
I mean, more of product procured, but I think we don't have an RCT or meta-analysis to really help us into do that.
Yeah, and just because I have no experience and because I cannot use it, I haven't followed it that much. I have to admit.
Makes sense. One last question, if you're okay with. What is your protocol? Now, a patient comes to you, an young chap, non-traumatic, partial cuff tear. How do you take him up?
If it's just partial,
Yeah,
so I would go first conservatively. I
lovely.
would, yeah,
So, so let's say you
um,
put him on. How long is your conservative program?
6 months.
6 months, lovely. So it's the God months. You go for the 6 months, you train your scapulars, you do everything. And then there are two categories. They're happy, you leave them alone, right? And do you leave them alone with an advice? You tell them to repeat MRIs, or you tell them no problem, you have.
Uh, I don't tell them to repeat the MRIs in partial lesions. What I tell them is to do their exercise. If they have pain, then we have to do an MRI to see what it looks like. And I just warn them that you have this and that. It depends always how big the lesion is.
Yeah.
Yeah. And then And then I decided. I give him maybe if it's an A3, for example, and I see it on the MRI, I'm like, okay, this is a chance that you have now. If it doesn't work, well, we're gonna work together for 6 months. Sometimes I do PRPs as well. I didn't used to do that before because hospital in Germany means just operating. You don't do any conservative, and but now I do it. Uh, if they go well, if they actually are happy, I just leave them. Otherwise, I go if they have again pain after 6 months, I might repeat the MRI and then maybe operate on them.
So if you plan to operate, do you complete your tears? Do you do plaster repairs? I mean, what's your philosophy on that?
Yeah. Um, I used to do lots of pasta repairs before. I didn't have the pain that everyone is talking about because I had a nice device. I had a kind of obturator and it was coming as a cannula in there. So, and then what I was doing, it's the same, it's two anchors, different spots through the,
Double
exactly. And I
pulley,
was
double
tying
pulley.
them together outside, pop, 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 and done. The thing is, now I differentiate the tears, the lesions. So if it's an A3, it's just go in and complete it.
Yeah, it does make sense.
Otherwise, if it's an A2, I don't know. I know there's some stuff I think from Imhoff, the superiority if you complete it, but still, if it's an A2, I don't want to open it up. I don't want to open it up. I want
You don't
to
get the
leave
freedom.
what you have, and maybe I cause anyway bleeding on the rest of the footprint, and then I bring my anchor in there,
Okay, so
like through a pasture repair, like transtendon.
and for you and your evidence, what do you think is most symptomatic? Bursal, articular, interstitial stairs for the young guys.
The intraarticular. Bursal, yeah, bursal. I don't see many bursal tears. I don't see many bursal tears, even though I was actually with a student talking to him about actually what we talked about today. I'm like, no, there is no bursal tears. That was last week. And I go in there and it was a bursal tear. So I did as a speed
Wow.
fix.
This is lovely. I think this is the most valuable of your talk because you're a person who loves sharing your personal things, and that's a day-to-day practice of a surgeon, and I'm sure the audience will be of benefit.
Just
Before
a
before
quick
I say
remark.
thank, can I have one very eager question because you gave a ad on me. What is your evidence and take on PRPs? Do we need to do that? Do we not need to do that, especially in these kind of partial tears? We know that in complete massive tears, it doesn't make sense. So,
Yeah, we see studies, there's evidence more and more that leukocyte poor, if I remember right, they actually have an impact. We see it more and more, especially in tendons. I don't know about arthritis, but in tendons, we see it more and more. It doesn't harm. I can say that. I can't say 100%. I can't say 100% that it would help. But at least it's something to provoke a better to cause some more bleeding in the region. Better, I forget the word now. So more
yeah, to
blood in
trigger
the
the biology, yeah, it makes sense.
yeah, yeah, yeah.
When you have a pasta tear and you're planned for a PRP, how is it that you go there? You just put it on the articular side, you go with the ultrasound, or you just put it on the bursal side? What
No,
is
no, no, no. I go directly where the tear is. I use the ultrasound and I go directly there.
okay, so you go into the spot and push it up there.
Exactly. I see it first on the MRI because I'm not a great sonographer, I have to say. I see where my biceps is and I go exactly posteriorly.
Correct. I think that's the point. I think any tear that's close to the biceps pulley because sometimes it's very symptomatic because of the pillar, and that's exactly where you go. Lovely, lovely.
And a quick remark, of course, in acromion type 3, Bijlani, there you can have a subacromial impingement,
Yeah.
yeah?
Yeah, yeah.
Okay, not because I don't want to say, oh, this is everything is intraarticular.
And,
No, no, no. Of course, there is still subacromial
at
impingement.
least to do the scope, we need some space.
Yeah, if I do a decompression, I do a bit just for the bleeding.
Yeah, yeah,
Just for the bleeding, actually, not because I get more space. And the good thing is, if you do lateral decubitus, or even if you use an arm holder and have
yeah.
it under traction, so you always have space.
Got me, got me. That was really amazing. So I think he's a very busy man. He's spot on, to be precise. So he's been so kind enough to come on time to be with us, to give all the talk. I would like sitting with him the whole day, asking him questions and personally learning from everything. But I don't think I'll do that to him right now. He's a busy man. He would his patients would miss him. His family is gonna miss him. But I take this opportunity because I think this is what I wanted this this kind of a webinar is we wanted to have a personal kind of an interaction, and we want to just listen the master's notes, because in orthopedics, and especially when sports medicine, shoulder surgeries, I don't think there is a definitive answer to every question. And the more you keep asking questions, you get more and more answers, and then you get to cross. So once we hear to the masters and the guys who've been doing this, it's easier for us to take it further to get the answers. And Dr. Christos has been so patient, and yeah, as I tell him, is always my good and honorable friend. But thank you so much for
You
sharing.
are as well. Thank you, thank you, thank you so much.
Thank you so much. And at the same time, thank you to Ortho TV and the whole team for supporting us. And Dr. Sendil, who used to join with me today, unfortunately, because of his other schedule, he couldn't make it. I think for the next time he would be there. And we would meet very soon in person, as with Dr. Christos as well.
Have a great day.
Thank you. Take
Bye
care.
bye.
Yeah, yeah. Bye.